Hi, I'm Mara Antonoff. I'm a thoracic surgeon at MD Anderson in Houston.
Kevin Lobdell, Sanger Heart and Vascular Institute. And my clinical background is a combination of pediatric and adult cardiac surgery as well as cardiac critical care.
Dr. Lobdell, I'm really interested to hear about the study that you just presented and some of the work that you've done with remote monitoring. I'm wondering if you can tell us a little bit of the background of the rationale for this remote monitoring and what the goal is by using these tools.
Yeah, great question. So about 20 years ago, this is the 20th year, we embarked on a quality improvement program. We started publishing the work that we did in 2008. And I like to think of the first 10 years as kind of an analog period. And then we started to get into things like telerounding and EICU, and that helped us change and improve. But then about 5 years ago, we thought there was a real opportunity to bridge the gap in care, both on the front end, preoperatively, but also after we discharge people with things like audio visual visits, messaging, the scheduling that they can do, and then collecting novel biometrics as well as patient-reported outcome measures. So we've been doing that under the name of Perfect Care since 2019.
And so you've got about 5 years worth of data at this point.
Correct. We've been at it since July 2019, and we've enrolled about 1,800 patients. At this point, while we're trying to enroll 100% of our coronaries, it's about 70%. And if you look at coronary valve, coronary plus valve, it's about 50% of our patients.
Wow, that's terrific. And what are you seeing as the benefits of utilizing this type of technology?
Yeah, as you might imagine, the things that we would like to prevent that are applicable to remote monitoring would be death out of the hospital, which is what we found very rare. We've only had one patient in that interval, and it was in a control group, not in the study group. But shorten the postoperative length of stay, reduce 30-day readmissions, even reduce visits to things like the ED or the ambulatory clinic, and then also discharge a greater number of people to home as opposed to cardiac rehab or an extended care facility. And what we're really thinking about now is a composite where we say a perfect care composite would be somebody doesn't die, they don't have a major complication, they have a short postoperative length of stay, they get discharged to home, and they don't come back to the hospital within 30 days for readmission. And we think what that does is it's high quality time at home for the patient. So we're really trying to redefine the standard for how that work is done.
That's great. What is the cost of this type of technology? How does that impact cost for the patient, cost for the healthcare system, for the community?
So we were fortunate to get a grant from the Duke Endowment to fund this for the first 3 years, and they allowed us to spend the money over 3.5 years because COVID sort of slowed the number of patients during that period of time. But once we finished that, now a little over a year ago, we've decided it's such a difference in care that we would fund it ourselves. And we think it cost for the standard digital health kit plus the remote monitoring through 90 days about $260 per patient. That's both for the platform and for the digital health kit. And what we've had to do is train our ambulatory care nurses to be able to do this work.
So that's extra training time and cost as well.
There's some training that went into it, but we did it all while they were doing the work. So arguably it's really cost neutral. But now if you look and just say we've gone through that training period, we're using the digital health kit, we're using the platform, we think the return on investment is somewhere between 14 and 24 times what we're spending.
Because of the cost of hospitalization, readmission.
Correct. And then the opportunity for throughput based on that. Now we're using benchmark data. We're now working on claims data, and we're also working on internal cost data to kind of refine that understanding. But we think that it is sort of common sense. If they're going home faster, they're coming back less frequently, and that we're only incurring, $260 per patient, that it's well worth the investment.
I can see the obvious application in the population of patients for whom you've been using this. As a thoracic oncologic surgeon, my obvious next question is, do you see this being applicable to our patient population for general thoracic surgery, where we still do have very high-risk patients and very challenging complications, probably more so than non-cardiothoracic specialties, but definitely the risks and the types of complications postoperatively are going to be different than the coronary or valve population. Do you see this being applicable for those of us who are general thoracic surgeons?
Absolutely, and even beyond that, if you just think about risk and mitigating the modifiable risk, having a set of eyes on people and novel data, which I think becomes simplistically like new vital signs, their sleep, their steps, that sort of thing, but ultimately incorporating into the risk models so that we can better predict who needs what and apply the resources judiciously. I think we'll begin to see it spread to other perioperative situations like neurosurgery, spine surgery, maybe oncologic surgery more generically. And it also is a very engaging thing that we can then learn how to better engage our patients and apply care appropriately. So it's been a terrific journey, and yes, I think there's great opportunity for spread and scale.
Does it require any special training of the patients? Do the patients need to be of a certain health literacy to be able to engage in utilizing these technologies?
It's a good question. There's no question that we wouldn't give it to somebody that doesn't want it, or we clearly didn't think that they could do it.
Okay.
But we find that's pretty rare.
Okay.
When we have looked at available data, say through the STS database, comparing race and their performance when we do, there's no difference. In fact, we saw a little bias towards non-Caucasian doing better than Caucasian, but I would be the first to say that it's rather rudimentary. We're not including all of the social determinants, but what we do think is we have a platform that works. It's markedly improved care when we look at propensity matching, and it gives us the opportunity to continually learn and improve from whatever dimension we want to look at.
It seems to me that publication of results demonstrating improved outcomes and cost reduction are going to be very helpful for anyone who wants to advocate for this in their healthcare system, particularly the financial component. I see us needing published data to justify the means of the cost and to present information to payers and institutions and those who kind of make those leadership decisions. When do you think we could have some good information that we'd be able to share with others in that regard?
Well, I think that the 2 publications that we've had help. It doesn't answer all the questions because some would still say, well, it was 2, but now it's 3 with today's presentation, 3 facilities. We're up to 1,000 patients that we've studied. We persistently see similar results with a step effect. So it suggests that once you start doing it, it works and it's persistent. But some of the financial data is going to take a little bit of time. So I think we're probably looking at, 6 months to a year to start to say maybe we looked at 1,500 and we have some bulletproof financial data to go along with it.
I think that'll be really helpful. Any pearls or pitfalls to anybody who may be looking toward introducing these types of technology into their practice?
It's a really good question. I've had to challenge myself because being on a 20-year journey, I can almost take it as a given that this was an important step in recent, but I have to go back and think about the culture that we created that was aspirational. They got aligned, they hold people accountable so that we perform at a high level. And so what I've tried to do is codify in the domains of people, so think leadership, change, teamwork, teaming, things like that, the technology being the second domain, and then the third being the operations, is how do we codify that so that we can help others do it? And that again, in the next 6 months to a year, I think we'll have solidified, and then it's really easy to both sell, if you will, say this works, and to help people do it.
Yeah, terrific. Well, this is incredibly interesting, and I think it's going to be valuable to all of our specialties as we move forward and can hopefully apply what you've done into many of our practices. I just want to thank you so much for your time and for chatting with us about this.
Thank you. It's a great opportunity.